I'm John Riefenberger, so you don't get Ted and I confused. I'm going to talk first, and
really
the
slides.
Oh. We're going to get to the next slide. We got the slides in the wrong order.
You could do my presentation if you want.
Yeah. Well, when we get to the slides, I'm going to tee it up for Ted and talk about how an HIE is an enabler for implementing ACOs, those things that you already got in place, and then what are the add-ons with that to start up accountable care organizations. When we get to the slides, my first one is going to pop up because I have a couple members of our sales team in the room, so I'll just tell you about that slide right now. It's Axolotl's been around since the mid 90s. Really the originator of web-based clinical messaging. We've got over 30,000 physicians connected, over 100,000 care providers in total. We have 7 statewide HIEs and over 20 regional health information organizations under contract, and 4 of our current customers are also Beacon Award winners. And I'll pause for a second, hoping that the slides come up. Or we could fast forward through dead slides.
We could go in backwards order, too.
Well, I only have a few points here, so why don't we just stay with it. So
there you are.
Okay. So I just talked about this slide here, and for my sales folks in the room, let them know that I showed the slide. An HIE has or provides the capabilities that is an enabler for the collaboration between healthcare participants. Part of what it provides, it's a connectivity enabler. If you got an HIE, you've got the connectivity enabler. You're exchanging data with hospitals and outpatient clinics. Ted's going to show you a couple of data providers that he has connected as both providers and consumers that are a little out of the ordinary with social services and first responders, and his efforts to also connect patients to this data. When you have an HIE, you're establishing an environment that's already based upon approved standards. So you've got that foundation to build on to keep adding more and more capability of exchanging clinical information. You've got, you're enabling care coordination through the exchange of clinical data. You've got an enabling infrastructure that you can go and build additional capabilities with. And what you have now is the foundation for the next generation of HIEs that we see starting up that are providing the use of analytics now with the clinical information. So what you have is an HIE that you can leverage to provide and improve the coordination and collaboration of care. You're going to have more data. You're going to have the ability to analyze both what was in the past only claims data and clinical information. You're going to be able to do real-time analytics and provide feedback at that specific point of coordination of care. And you've got another piece to your sustainability model, and that is providing services to ACOs, that infrastructure that we just ran through that makes it easy for them to get up and running. So the final slide here leading into Ted's and his presentation, which he did on his own, follows this perfectly. You know, what we have today is we're able to push discrete clinical information. We're able to collaborate already between participants either through an e-referral process or just sending clinical information to other care providers in your community. And then accessing a community-wide patient view of, or I should say, view of the patient data. What we're going to be seeing, we're starting to see now already, is the final two, and that is the care and population management through the use of analytics and decision support. So with that, I'm going to let Ted take you to a deeper dive into the weeds of what they've done up in Rochester.
Thank you, sir. I'll pause for my slides. Is that what we're doing? I'll wait. So I have to first admit that I am not a state CIO. I'm not a state HIE. I'm even more mythical. We're a RIO. We're branded that way. So even though that's sort of a deprecated term in New York, I take consolation in that I think 2 weeks ago or so, the Voyager mission just sent back some information on magnetic bubbles in the heliosphere. And what was really encouraging is it recorded it on an 8-track tape. So I'm hopeful that RIOs at some level will still be here. We're not, I don't think, the 8-track of the world yet, but you know, we'll see how that goes.
Hardly.
What I do want to walk through is to really look at, we've been doing this for 5 years now, and I do think there's some lessons for state HIEs. And I think there's some interesting lessons for ACOs as well as it relates to health information exchange. So really quickly, we heard yesterday, I'd heard of red and blue states. Actually this morning, New York is a yellow state based on the earlier presentation, where New York does have over 10 HIEs that are up and running in the state of New York. We're sort of in the, sorry for the other New Yorkers here, but we're in the prettiest part of the state, which is in the Finger Lakes, kind of in the middle west. We go up and down from the lake down to the Pennsylvania border. So our region is just 1.3 million patients, 13 counties, both rural. We heard from the inland northwest, a lot of rural issues are a little different than urban, but we also do have Rochester, which is a very urban area as well. Briefly, timeline, not to really sort of fluff feathers here as much, but as the states look at doing things, it's sometimes interesting to see how regions have moved forward. We spent a good year or two on policy development, really piloting services in 2008. And I would say we really got to a tipping point around 2010, some would say 2009, and we'll kind of go through that before I talk about more salient issues. This is the scary technical slide that I have to have. I think you can see the top. So at the top are our data sources. We right now have 16 hospitals, soon to be 20. We're sort of an anomaly. We don't have any national labs, so you see those 3 labs up there. Between those labs, those regional labs, and our hospitals, we have all the labs in the region. We also have all the radiology providers. A little different is we also serve up not just radiology reports, but radiology images for a lot of the providers. Another thing that's a little unique in here is that we have not only your traditional radiology providers, but for home care settings, we bumped into mobile radiology providers that were sort of running around in PT Cruisers. And that was yet one of those things in our grant we didn't know about. They knocked on our door, and we've got several of those hooked up too. The other things that John mentioned we'll talk about a little bit, we have EMS providers connected, elder care agencies, and we're working on getting perinatal providers connected. The user profile is, again, a little different, and I think this is where it's maybe instructive for ACO efforts going forward. We started traditionally with the hospitals and the physicians, but we moved quickly out into both sort of on either side, the long-term care, home care settings, urgent care, behavioral health providers as well. We've actually been working with behavioral health providers for a while. And we're now at this sort of lowest level to the farthest extreme, working on connecting EMS providers, that's going on today, and then consumers through our portal services. Just a real brief thing in numbers, because I think as everyone sort of moves through this space, you hit these lulls of frustration where you build this infrastructure and you're just not getting a lot of adoption. I think you'll see in the next slide that it's really data that sort of drives adoption. But you'll see where we are today, 1,200 physicians, almost 4,000 users. We connect to some 14 different EHR systems that make up about 140 physician practices. New York is a consent model that's per covered entity, so a lot of our value proposition is driven by this consent, and it has actually driven a lot of our focus on patient engagement, which I think when you look at an ACO is another place you have to focus on. But when we looked at sort of our RIO, we really started, again, the RIO term, we really started traditionally with hospitals and labs. It was a very discrete sort of clinical exchange. There were two communication patterns, which is the push model of sending results out like direct, and a query model, which needs consent. The expanding landscape that we saw, though, and we're still sort of moving through this in many ways, is we have several medical home initiatives that have been going on. We have both payer-based ones. We have some federally qualified health plans that are setting up medical homes. We have a local ACO-like effort that's through an IPA that's got an integrated delivery network. We also have a series of community-wide care improvement initiatives which have a lot of community focus and a lot of clinical workflow pieces related to it that look like a sort of medical home or ACO care improvement type process. So thinking through, and you can replace RIO 2.0 with HIE 2.0 or state HIE 2.0 or whatever phrase you want up there. When we look at sort of what we needed to do to support those ACO efforts, we sort of targeted a couple very discrete rule of three kind of thing. It was improved care coordination, improved patient engagement, and analytics. And you can kind of see where we had that core circle in the center. We're now sort of moving out to a much broader interconnected community. Within the care coordination piece, we really looked at a couple discrete things that we could do, and our challenge as a multi-stakeholder collaborative is really to focus on what we can do. I mean, we're not deeply entrenched in clinical workflows across 20 hospitals, across 4,000 users, but there are some things we can do. So we looked at new communication patterns, we looked at additional sources of care information, provider and patient relations, and we'll go through some of those. We heard some interesting things, I think, the first day on EHR interoperability and costs and business cases. There's also some interesting things that we've sort of learned painfully, and you'd think everyone would know some of these things, but each one gets to learn them, unfortunately, differently. So our initial model was a push delivery model around EHR interoperability. Within that, there's all sorts of fun things with filtering of data. You know, you'll stand up a practice, you'll start pushing them results, only to find out that the practice wants to turn them off because they're getting too much information. I mean, it's really a function of if they're named on those hospital reports and you're sending them all the reports that are copied to Don, they can drown. So we had to sort of build a way to clinically filter those for them. There's also issues around data providers turning off paper. There's an intriguing liability question a lot of data providers have, particularly radiology providers, which sort of required us to really get physicians to sign off on a per-point basis, basically, and hold the data provider harmless on the delivery of information. If you think about it, many of the data providers are used to faxing, and they own that fax, and they know how it works. But when they start going through an HIE and an EHR hub and through the internet, there were questions about, well, how do we know that the result got there? And unfortunately, we could tell them we have audits, we go so far, but once we send it to an EHR hub, a lot of times those EHR hubs in turn distribute it out to the practices. So we really couldn't 100% of the time ensure that they were actually getting those results, unfortunately. When you look at that distributed landscape, even with an email model with the push, it's going to be something where you send it out to a clinical email and you hope that they pick it up, but still there can be issues. We've moved quickly into two-way EHR interoperability. I think everyone's moving towards that, where the practice can both consume data from the HIE as well as send a CCD out. And those CCDs are both sort of a referral as well as posting it back up to the HIE. There's some interesting workflow issues around that. You know, does the practice consistently send the CCD up to our HIE, or is it a function of an explicit push? And so those are sort of practice configuration patterns you have to walk through. Where we really start moving, I think, into more configurable ACO support, though, is the idea of subscribing to information. We had a lot of physicians come to us and say, well, that's great. I'm getting my results. It's great. I can go on the exchange. I can view the information, but I really don't want to. I'd really just like to get notified when a patient has been admitted or discharged or shows up in the ED. We had a lot of physicians, and I'd love to find out about the death registry, where physicians were really trying to figure out when patients died, too. It's a big issue for them. So this subscription and notification piece is something we're moving in right now. The other piece that's been very much a focus for us is to move into a mobile model. When we look at the users of our HIE, 15,000 queries a month or so, a lot of results, 400,000 results were sent. But when you look at who's querying the HIE, it's often not physicians, it's their staff. And the problem that physicians have raised is that, well, I'm not in front of my computer, I've got a phone, I've got an iPad, I really need something else. So I think this mobile approach is really going to be a very big focus for us going forward. The other piece, and we heard this repeatedly this morning and yesterday, is that the types of information need to be broader than just lab reports and radiology reports to really move into a care coordination, workflow, quality improvement kind of mindset. And you'll see there's a variety of information here. These are the things we've been pushing forward on. I would, and I'll have a slide or two on that, but we walked into issues where we had admissions and discharge information updating the HIE, but they wanted more complete data based on those results. We walked into eligibility information, but people wanted more eligibility information is available. These lower three entries here, or bullet points, again, are more ACO based, where we're seeing the need to update the HIE from our care engines. So case in point, many of our ACO-like partners have a disease management program. They'd like to inform their other partners that aren't necessarily on that disease management program about a patient's condition. So they use it to push back up to the HIE. Patient data coming from PHRs, I know that's sort of a holy grail. We're working on that. We're piloting it this month. I wish the world were as simple as the blue button, but we, again, find some complexities there related to physician control of that kind of release. And lastly, some of the data here we're moving into is getting kiosks. We're very fortunate that we have a lot of employer participation in one of our large market changes, putting in internet-capable kiosks across their, I think actually Wegmans is down here too. Wegmans down in the Mid-Atlantic, you must have Wegmans markets, right. So they've committed to putting in internet-capable kiosks for blood pressure monitoring where patients can come into our portal and then that data they can enroll, and then the data from the kiosk can update our HIE and then be sent to physicians. Now, this is scary, and I don't know that you can read it really, but I can walk you through what the colors are. The reason I throw this up here, other than the color chart, we've been working on care coordination for a while in Rochester, and we finally sort of sat the three sort of business partners, if you will, home care, long-term care, hospitals, acute care, and sort of said, okay, what documents, what information do you think you need to make this process work better? So here we have the acute care setting ranking things, the long-term care setting ranking things, and the home care setting ranking things. So what was very curious to see in these kind of community discussions were where the acute care setting in green would look at the long-term care setting across the table, and these are big community meetings, going, why would you need that information? And the long-term care setting was so I could place the patient. And the home care, and so you'll see there's some variation on what people think they need. And yet you need to sort of resolve that and then be able to serve it up if you're really going to support those kind of use cases. This is one where you look at a CCD, you look at a patient summary, and you go, okay, well, where do those assessments fit? You know, where does the MAR go in? But more importantly, where are some of these more social, softer assessments fit into some of the existing standards that everyone needs? And I don't know the answer, but I hope folks are working on it. Some of the care coordination information we saw was completely invisible to physicians. And again, we heard that before. Some was sort of appalling to us. We heard about EMS providers, I think, earlier today, where, you know, I think it was the chap from Intel who was talking about seniors calling up EMS to really just have some social supports. Well, what we've seen in our community is some 20% of the calls don't result in a patient transfer at all. So that care information doesn't really go anywhere. Of the information that does go somewhere, it really only goes to the hospital. It never gets back to the primary care physician or a community physician. It goes into the hospital. A lot of it actually just goes back to state systems. And I think as states look at how they can facilitate ACOs, both this EMS information and elder care services information are two places where I think states have a real sort of oar in the water on this, where regional efforts really will struggle to try and pull this information forward. In a similar place, we have some 37 elder care agencies that are providing ostensibly social services information for seniors, but they're doing med reconciliation, nutritional screening, they're doing, monitoring falls at home. I mean, when we walked through our physician advisory group with all the information that was on these social assessments, essentially social assessments, they were sort of amazed that someone was in the home collecting this information. Initially, we thought we would pull a few data elements and make it available to them. And they were like, no, we want the 6-page thing. So this is actually rendered with a web service. It's brought up real time because, again, these assessments are updated all the time. So it's not like a lab report that we can just ship and post on our HIE. It has to be rendered sort of dynamically. And again, for the states that have elder service programs or EMS programs, we had to sort of champion these causes through our own state agencies, and it was sort of fun to get done. The other piece that we're starting to see related to care coordination, and I think some people talked about it earlier as well, is being able to manage the relationships of patients, even though you don't know if they've been enrolled with you yet, but at some point you will with an ACO, but to manage those relationships or at least document them so that when we're doing results delivery or when we're doing analytics, we will have those relationships available so that we can aggregate the data or submit the data to all the principals within a care zone. Right now we're doing this on a results delivery basis where a physician will say, oh, I'm working in this medical home, I'd like my results sent to their care engine as well as to my own EHR, and we can kind of do that. Where you're all looking at building provider directories at a state level basis, this will become really valuable to have a way for people to use a provider directory to map that. Same sort of thing here, just being able to provide analytics on those relationships of physicians and patients is going to be pretty crucial. On the patient engagement front, we've heard, and it's a challenge for a lot, we spent a lot of time, all household mailings to 400,000 households, movie theater spots, newsletters. A lot of the reason that Rochester Rio actually comes up on Google searches is because we used a PR firm to get into our local media as a way to make sure patients knew what was going on. It was a really cheap way to advertise. So I apologize for all those Google results that you get on us. But it's worked for us. Our consent rate is about 98%. And we've got about 500,000 patients, which is about a third of our market area, so it's working pretty well. And when we look at our sort of funding model, our business model, being able to get PR at a cheap price is very attractive to us. We have patient portal services now where patients can set consent. They can request audits. That's a big feature. People like that. They can also attach an advanced directive. We've had a big focus in our area about end-of-life planning and advanced directives. The piece we're just moving into, and this was sort of pre-meaningful use, and it was fun to watch the hospital's responses to this 2 years ago when we started thinking about this. They were very nervous about providing patient connectivity, and they were sort of like, well, why would you want to do that? And we were like, well, our employers and health plans who fund some 2/3 of our operating expenses really want to get patients engaged. And they're like, oh, okay, and they came along. Now with meaningful use, they're all looking at how they can leverage this service, and so we're sort of re-engineering it a little bit so it's more hospital-centric as opposed to physician and patient-centric. The kiosks I mentioned, the nice thing about these kiosks as well is most of them have a place for a USB drive so you can put in your home monitoring, whether you've got an Omron or some other type of cuff or pulse oximeter. We met with Wegmans, and even as they started rolling these things out, I was looking at their charts and their responses, and they were getting a lot of readings from pulse oximeters. And I was like going, well, wait, you don't have a little prick thing here in the, it's just a cuff. You wouldn't do, and they're like, no. Well, where are you getting the data from? Because, well, people are bringing in their USB drives. And they didn't really even promote this. And I was going, well, why are they doing that? And they go, well, the kiosks have these really great pie charts and trend lines, and they don't have them on their home monitoring things. And they bring them in here, and they're actually using the kiosks as sort of their own little private portal. So, well, that's great. The other big thing for us thinking about ACOs is how we link to not just the care engines and the disease engines that we talked about, but a lot of these care engines or medical home engines or whatever you want to call them usually have a communications module that's pretty significant. It's either text, SMS, voice. So when, again, we go back to, I think it was Farzad's cat example or my oil change example. You get reminders on those, but you don't get reminders from your physicians. So what a lot of these engines let you do is set up reminders based on either your practice management system or your EHR. So we want to pull that information back to the HIE so that not only the people that are sort of within the ACO might be able to see this stuff, but other care providers, whether they're in the ED or a home care setting, that may not be directly related to the ACO or the home care zone, but they will at least know that the patient has been, physician's trying to reach you. I see the physician's been trying to reach you for 2 weeks to come back. You might want to do that. The health analytics piece, again, is something of a holy grail. Most of us HIEs have, many of us have, I know there's some concepts of data banking still out there, but many of us have a federated model. We've already built out a framework to move that federated model into a normalized 33-some table centralized, analytic engine. And so that's sort of what we're going to be doing moving forward. And when we look at that, the nice thing about that for an ACO is they can see the data outside of their system and within their system. It's real time. We're fortunate we have an all claims payer database already built by another entity within our region, so we can link to that going forward. I think the challenge for us, and as we look at this, we don't want to oversell what we can do as an HIE. It's not clear to us that we'll have the N from all the EHRs. I mean, a lot of these quality measures need certain metrics, how many patients are this and have that kind of thing. So that the sample size or the N, we won't really have coming out of the EHRs. So the question I think some raised was, how much, I think one hospital responded or health system responded, whether they'd want the HIE actually doing any of these analytics. I think the bigger question for us is how far do we go with it, given the fact that we don't necessarily have all the EHR data. Our data feeds are coming from hospitals, labs, and radiology practices. So one way we're looking at this is we may slice the data and pre-stage it for those entities to then consume into their own engine and provide it as sort of a limited analytic service that will at least get them the stage data they need. But we'll be exploring how much more we can take, that model and actually do more of the analytics. The nice thing of working in Rochester is it does have a very high collaborative threshold. So where we sit around and we have one analytics company over here and we have the health plans over here and we're the Rio over here, those conversations are really easy to have to say, okay, we only need one entity doing this. Who's best suited to do it? And then we just let that entity do it. So we don't really spend too much time arguing about it. So when we look, again, replace Rio for the states, replace that for, I guess you could be a HISP, a HEO. In the old Marco world, you could be a SNO. Our HIE efforts to date are really sort of foundational. And I think as we look at the ACO requirements, medical homes, behavioral health homes, it really becomes an issue of additional data, more than that clinical data, and different communication paradigms other than just pushing and querying. I mean, the subscription model, I think, is fundamentally the next thing we have to really support. So I consistently throw a lot of stuff on my slides, and I'm sorry, but if there's questions now, we can do questions. Any questions? Yes?
What's the end on your last slide?
Well, if you look at a lot of the measures, you need to be able to find out, of sample size N, how many patients have had this test done. And because we don't actually have the EHR, we don't necessarily know what that population number is for them. So we can only go so far with it. Yes?
Oh, there we go. You mentioned, and by the way, Wegmans is a great grocery store. They don't have, you're putting blood pressure cuffs in places like Wegmans to then feed the HIE. Where's that data going, and are people resistant to how valid that may be? Because you see them at CVS or whatever. How many people end up just playing with that as something to do while they're waiting for things? And are those going to be monitored a little bit more than what you normally see?
Well, that's a good question. A lot of physicians will look at the different devices out there and then go back and say, okay, well, how rigorous are they? And you're right. When I do one, it's usually because I'm waiting for something else. And where we've actually had sort of tests of kiosk, this and that, you do get some variation. So when we look at it, because it's a real simple thing to do, we're looking at it as sort of an adjunctive kind of thing. And we actually provide the attribution that says it was from a kiosk. So physicians just don't get this reading and think, another clinician took it. We're hoping, if anything, it will be indicative that they might want to follow up on it. So if they see a patient going to a kiosk and it's been repeatedly high, they might go, I don't believe that. Well, that's great. If they don't believe it and then they do the test themselves, that's not a bad thing either. But you're right, that the veracity of those is a question. The model that Wegmans is running out is the Life Clinic model, which at least has been pretty well vetted by the physician community. The home ones, though, then when they start sticking in a USB device, will be this whole other, because we won't know how many different USB devices we're getting feeds from. So the actual kiosks, I think, are pretty well trusted, but there's a lot of different cuffs on the lower shelf in the pharmacy that you can pick up, and you're right, it is a question.
I believe you used the term physicians could be drowning in the amount of information that they're receiving through their system. Is there a concern, that they maybe have some extra legal liability for receiving information that for whatever reason they didn't have time to review, whatever, it's in their inbox, but they didn't get to it?
So, two good points, but sort of 2 points. So the drowning piece is one where right now things will come on a fax machine, hopefully, and someone in the office can go like that with it pretty quickly. When it comes into their EHR, it's in either their unidentified queue or their work queue, and they have to work it to get to the ones that, they really have to go through something. So what we saw was, for instance, prelims, and it varies. Some of our clinics wanted prelims and wanted all the inpatient tests they could get. Some physicians were like, no, stop that. Turn that thing off until you can filter this for me. The other issue, so the issue that you raised, the second one, though, about the liability, we have seen that. We still have a few physicians in the community who will not use our portal because they're afraid that once they do, they'll be liable for all the information that's there. So the whole, community care standard issue, sort of, for most users, at least for 4,000 of them, it's been resolved. But you will find care providers that just will balk at that. And as much as we bring lawyers together and talk about it and other community leaders, they still have that issue. And it's one of those fights that we just move on from, unfortunately.
Yeah, and there's a capability, when you talk about physicians drowning in data, of sending every clinical result where that physician is a physician of record. And a lot of times when we are feeding a third-party EMR, we are asked, and we have them sign off on a statement that I only want clinical information where I am the ordering physician.
So we have actually had to create a series of little forms, as much as I hate little forms, where physicians can check, what types of data they want. And then for their data providers, they check and release, particularly the radiology providers, they check and release for the data providers that they will not, go seek injunctive relief against them should there be a malpractice case that, the data provider provided the information as best they could. If you look at, I think it's the American Academy of Radiologists, they actually have some guidance on, how results are supposed to go to physicians, and they do say that physicians have a certain obligation to make sure they get them. But it was an interesting place because it just came up from the radiology practices, and I think in particular related to cancer diagnosis and things like that.
I just wanted to add, not to belabor the point, but John Kansky from the Indiana Health Information Exchange, we also have occasionally, rarely but occasionally, heard this argument from physicians that don't show me the data because I don't want to know. Now, I wouldn't want to have that person as my physician, but we did approach our attorney about that, and one of the things that he said, and I'm not going to come up with the term, but I think it's something like standard of care. There's this legal term that at which point in time participating in a health information exchange and having that data becomes the standard of care, you could actually be negligent for, Vicky's nodding her head, the attorney, thank you, for not allowing, partaking of that data. So I just wanted to make that point.
So that's where we keep trying to sign up more than 4,000 users. If we double it to 8,000 users, we can make that standard of care argument. I mean, we're pretty close to making that now, at least some of our hospitals would say we are. No other questions? Oh, there's more questions. Okay.
John, you mentioned the next wave could be supporting clinical decision support. I guess I want to get more into how near-term that is and how many years out that.
Well, we're beta testing right now and working with his company to move our federated data model into an analytics engine. And we've been actually using it for operational reporting for the last, I guess, year. And it was sort of fundamental for us to build our business plan because we had to go back to the employers and hospitals and health plans, and we created a series of dashboards for each entity and showed what we were doing, and then they were willing to pay us. So we get money, we pay bills, it's good. The analytical piece, I think, is going to be a little bit of a discovery for us, and we're still, because again, we have this issue as an organization, and I know what bioinformatics folks do and what they cost, and as an organization, do we staff up for that? I've had departments like that, so we're fortunate in another community organization has those skill sets. So we have the framework, the data framework. We have the BI tools, business intelligence tools there. And I would say by this fall, we're actually running on a CDC grant using those tools and a avoidable readmission ADT kind of grant using those tools, which we'll be running through starting really now. We've had our first couple kickoff meetings into the fall. So I don't want to speak for the vendor that actually provisions it, but for us is using this sort of proto tool, we're looking to start using it on an operational basis by fall, the end of the year.
And we working with Optum, who bought us, who under Ingenix had extensive claims-based analytics already in place, are working to combine the claims-based analytics with the real-time clinical information. Because as we all know, it's usually in the billing part where we actually do most of the diagnosis through the use of coding. And so I don't know what that looks like yet, but I know it's going to be a very, very powerful tool.
There was a hand or two in the back.
You mentioned that some of the home health folks had USB ports and they were plugging devices in, whether they be the blood pressure cuffs. What steps do you have or what processes do you have in place to ensure the accuracy of the data that's being uploaded to your system?
So if that's related to the sort of similar question around the kiosks, as an HIE, I hate to be blunt, but we don't. And so similar way, if it comes from a PHR, we put the patient attribution on it, but we can't ensure anything beyond what we get. So when we get a lab test, we don't play with it. It's what the lab gave us. I do think that these home results, particularly from physicians, they said, well, they made it clear that they wanted that patient attribution, and we're doing that. But beyond that, there's not much we can do. Other questions? No? Going? Gavel, 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 down. Well, thank you very much.